This podcast is intended to provide information for educational purposes only and to serve as a starting point for you to have a conversation with your personal physician. Nothing stated on this podcast should be considered medical advice. Consult with your physician before undertaking or changing any treatment plan.
If there's an option for profitability, people move into the space and it kind of all works out naturally. Healthcare doesn't allow for that process. Healthcare prices are set arbitrarily and randomly. Welcome to episode 26 of the Pound to Cure Weight Loss podcast, titled Ablation Conflation and Healthcare Inflation. Zoe is not here. She is on her honeymoon. So I have brought in Deidre. Many of you in our practice know Deidre. Deidre is pretty much my right hand. I can't really do much without Deidre being involved in it somehow. She assists me in the OR. She sees all of our patients preoperatively and postoperatively. She makes sure everybody's prepared for surgery. Our office runs extremely well. Our patients get tons of support and education. And honestly, Deidre plays such a huge role in this. We've been working together for how long now, Deidre?
Since I was here before you came here.
Yeah, Deidre beat me to the
whole
punch.
time you've been here.
So over 5 years.
Yes, I've been in this bariatrics for almost 9 years now, 8.5 years.
Yeah, and we've probably done, what, 1,500 cases together?
Yeah, at least, a lot.
A lot
Not
of
including
cases.
the revisions and the emergency cases,
Yeah, I think, a lot of people think, Dr. Weiner, he's a surgeon. Here's what you don't know, is that I'm not that good if Deidre's not around. Like, it takes two people. She knows every step. She kind of can read my mind a little bit in the OR, and that makes it so that I don't have to think quite as much.
All right. Two sets of eyes is very important in the OR.
Yeah.
Nobody's, each of us not perfect, together, much better.
Another little thing about Deidre. She's the only person to ever call me Matt, which I actually like. That's one of my things I'm kind of working on. I want everybody to call me Matt instead of Dr. Weiner that I work with.
I was in the operating room before I became a nurse practitioner. I was a nurse in the operating room. And like the very first thing I call you when I meet you is what I'm going to call you for the rest of your life. And so, an operating nurse can't call a doctor Matt, so.
But you can now.
It's been Weiner from the beginning. And probably forever.
She's called me Matt every now and then. The other thing Deidre is she has absolutely no problem telling me I'm wrong and telling me that she disagrees with me. And also that makes her so valuable. Like that is not a downside. Like I need people to keep me.
Somebody has to do it.
Yeah. It's a big job, right?
Yep. I don't like being a devil's advocate, but it's necessary.
Yeah. So anyway, well, welcome, Deidre. We're going to have a good time hosting these next two podcasts. So let's move into the news. This segment is from Forbes, and it's called What to Know About New Minimally Invasive Weight Loss Procedure, Gastric Mucosal Ablation. So we see this every few months something new comes
procedure
out,
that's minimally invasive that's going to cause weight loss without surgery.
Right, the balloon.
Right.
Do you remember that sheath that you would put over the first portion of the duodenum? That thing was a disaster. That caused all kinds of perforations.
Not a good idea from the very start.
The hooks would penetrate into the blood vessels and cause massive
Seems like a good idea.
Minor problem. So this was a study they did on 10 female participants. The average age was 38. The average BMI was 40. So these are people who would qualify for bariatric surgery. And they perform what's called endoscopic mucosal ablation. I actually do quite a bit of endoscopy in my practice. I think as a bariatric surgeon, you kind of have to be good with the endoscope. We use it in the operating room a lot when things are tricky, when we're doing these complicated revision procedures. Kind of being able to look from the inside can be very helpful to figure out what's what. And so what they do in this procedure is they put a scope, they put you to sleep, they put a scope through your mouth. It's an outpatient procedure. And the first thing they do is they do a saline lift. So they inject saline kind of just underneath the lining. And what that does is it protects all the tissue beneath the stomach lining. And then they use something called an argon beam, which is a laser. And they burn the what's called the mucosa, which is just the lining of the stomach. And so they do it only in the fundus. That's the portion of the stomach that we remove during a sleeve gastrectomy.
The part that stretches, that allows you to eat, past your portion size.
Exactly.
Right.
And so they looked at weight loss outcomes and they showed 8% total body weight loss. What do you think about that?
That is, I mean, 8%, that's nothing.
Nah,
Nothing,
right?
yeah. Not impressive.
Yeah, not so impressive. At 6 months.
Yeah,
So
even
18
less,
pounds.
even less impressive.
18 pounds on average. They did decrease ghrelin production by 45%.
Well, because ghrelin is produced in the fundus.
Right.
So, you're blunting that production until the mucosa goes back, and which is what every
Week or two?
Yeah. So it's not going to last very long.
They may
right.
damage it, and it might take longer than a week or two.
Right.
But your gastric mucosa turns over very, very quickly.
Right.
And they decreased hunger cravings by 43%.
Which makes sense because you're not producing ghrelin. But I mean, these people are going to gain all the weight back.
Yeah.
There's no way that that's going to be long lasting.
No, I agree. Not impressive.
No.
Yeah.
I mean, diet and exercise alone, 5 to 8% weight loss, right?
Absolutely.
So.
To me, this is equivalent to nutrition.
Mm-hmm.
And my hunch is they also had these patients make some nutritional modifications. So they didn't talk about placebo, but really to do this study, especially with such modest weight loss, you would need a placebo group.
Well, they only had 10 patients.
Yeah.
So.
Right. Yeah. And the article talks a lot about the lap band. So, any article to me that talks a lot about the lap band.
That's a warning sign. That's a red flag right there.
Right. There's not a lot of research being done.
Right.
I mean, I haven't put a band in it in 10 years. There's not even that many out there.
It's definitely fallen out of favor for sure.
How often do you see a patient who still has a band in? I saw one today, actually.
Yeah, I mean, occasionally because we do band adjustments, but I mean...
Not a lot.
Yeah.
Not as much as we used to.
Not very many people put in new bands because they're not great in the long term. So
yeah, to me, that's immediately suspect. I think we know what the story is with the band. And in my mind, any provider who's still putting in bands is doing it for their own benefit, not the benefit of their patients.
Absolutely.
Yeah. So the other thing is that this is totally not applicable to bariatric surgery patients, right? How can you ablate the fundus after a gastric bypass or a sleeve?
You can't.
There is no fundus after a sleeve.
Right.
And after a gastric bypass, there still is a fundus, but it's no longer connected.
Right.
It's no longer connected. So Deidre, let me ask you a question. Do you know another term for mucosal ablation?
Yeah, an ulcer.
An ulcer.
An ulcer, right? An ulcer is a wound in the mucosal lining.
Yeah.
So it's the same thing.
So they're essentially inducing an ulcer. That's another thing we've seen. And quite honestly, they mentioned the lap band, and I think that's something that I saw a lot of times with a band is that people get sick.
Right.
It's
Reflux,
too tight,
vomiting.
Esophagitis, just really, and so they lose a lot of weight, but illness causes weight loss.
Right. They're miserable in the process.
Yeah. And then as soon as you resolve that illness, then people gain weight back.
Because they can eat again.
But it's not real weight loss. It's not set point lowering weight loss.
Yes, absolutely. It's weight loss it's punitive weight loss. Weight loss by punishment.
Exactly.
Yeah.
And so my concern is that that's where this is. And I think the final thing is, there's an industry behind this.
I mean, if they're talking about the lap band, there definitely is.
So there's the argon beam maker is who sponsored the study.
Of course.
So there's a company that wants to sell more argon beam machines. And so that's where this is coming from. So I think, this one to us, I think, I don't know, I'm giving it a thumbs down.
Yeah, definitely.
Double thumbs down as a future of weight loss. I think this one's not quite as good of an idea as the balloon.
Anyway, to start.
All right. Well, yeah. So this in the news segment, I think, didn't make the cut for something that we're going to see a lot of in the future.
No, definitely not.
But I think it's important too, as you look at these new treatments. Just because it's new
doesn't mean it's better.
Doesn't mean it's better.
You have to look at it critically. What are the long-term side effects?
In medicine, new is usually worse.
Well, because it's untested. It's
Untested.
untested in the long term.
The things that are still around have really been proven.
Stood the test of time. Yeah.
And that fact is lost on a lot of people. And there's a lot of surgeons out there and a lot of other manufacturers out there like, I want to do the new thing. The new thing is going to be better. We're going to brand it. Everybody wants to get in on it. And we've seen that time and time again. I mean, the world of bariatric medicine, both on the medication side and on the surgery side, is just littered with failures.
Yes. I mean, I think the gastric bypass is the perfect example. It's the surgery that stood the test of time, right? It's the most effective long-term.
All right. Well, let's move into our patient guests. We've got Barb here. Barb is actually our coordinator at Tucson Medical Center, TMC, which is where we do all of our surgeries. And she's really a bariatric veteran in many senses of the word, right?
Yes.
So Barb, why don't you just kind of share how you first got interested in bariatric surgery and where this all started with you as an individual, but also as a nurse?
Personally, I chose to have bariatric surgery in Mexico.
Interesting.
Oh, that is interesting.
Wow, I
Did you
didn't.
just not
How did
have
I not know that?
insurance coverage or
Exactly.
So tell us that story.
I went to Mexico for
So,
lap band.
so first of all, you're a nurse.
I am a nurse.
You were a nurse at the time of the lap band.
I was a nurse at the
Yeah.
lap band. But we're talking 10 to 12 years ago.
Absolutely.
when coverage was scarce.
Right.
Not-
So the band was 10 to 12 years ago?
At least.
At least. I was going to
Okay.
say probably more.
Yeah.
Maybe
Probably
more.
15
That's-
years ago.
yep.
Yeah.
So I went to Mexico and paid cash for it.
Right.
Thinking it was the
So
better choice.
Zero coverage.
Zero coverage at the time.
And what was the price in the US?
Probably maybe 12,000, 15,000. In Mexico, it's 5.
Yeah.
Which, I mean, compared to a bypass and sleeve, that's almost the same price. So it's significantly more in the U.S. than in
Right.
Mexico. You can get a sleeve now for that cost,
Right.
slightly more than that.
Right.
Yeah.
So 20
Yeah, the
years ago, that
device
was a
was
lot.
what was expensive.
Yeah.
The lap band was like $3,000 or $4,000.
Yep.
Right.
So you went down to Mexico. What was that experience like?
The hospital had armed guards. It was in Tijuana, outside of
Yeah.
Tijuana. We were picked up at the airport and transferred down to the hospital and then transferred back. The coverage, that's part of the disappointment part, is getting follow-up maintenance for your band.
Right. I was going to say, was there
Right.
any follow-up at all?
None.
Yeah.
So where did you have to have adjustments at here in town?
So that was left to my own devices. And fortunately, because I am a nurse, I knew who to call, whom to
Right.
call.
Right.
I found someone that came out of the White Mountains that came down to Mesa every
Oh, wow.
month.
Wow.
She would do the adjustments
Yeah.
in the
Yeah.
office. And if it was too tight, you were kind of
You were out of luck.
out of luck
Oh.
until the next time she
Sorry,
came
you have
into
to bomb
town.
until we
Oh
see
my
you again. Right.
That,
Jeez.
you know, I don't think a lot of people really understand the beginnings of bariatric surgery and how different things are now. I think you probably understand that better. So you had this lap band, and it sounds like not the best experience. Did you lose much weight with it?
No, I only lost about 20 to 25
Yeah,
pounds.
yeah.
And then I started having complications, nausea and vomiting,
Right,
inconsistent management.
right.
My receptors were always elevated. Markers, the
Yeah.
receptor markers. So I ended up going for consult for consideration for bypass, and my insurance denied me.
Yeah. Yeah. So you didn't have coverage to begin with. Did they deny you because they wouldn't cover bariatric surgery, or did they deny you because of a once per lifetime clause?
They denied me because of
Non-covered
Non-
It was
Non-covered
exclusion
benefit.
completely.
non-covered
Exclusion.
benefits.
Yes.
Yeah. Okay. So you don't have coverage at this point. They say bariatric surgery is an exclusion.
correct.
So what'd you do?
So I dealt with it for maybe a year and a half, and
Kept the
then
band in.
kept the band in,
Yeah.
and
Were
left
miserable
it.
during that time.
Yeah.
And left it with no adjustments. No,
Right. That's
no
probably the best
saline.
thing to do.
Yeah.
Constantly had GERD,
Yeah.
treatment for it. Eventually, I ended up with aspiration pneumonia.
Yeah.
So that was my saving grace.
Yeah.
Unfortunately, I had to get sicker before I could even
Right.
be.
You had to have a medical complication before
So
they
the
would prove it.
diagnosis of aspiration pneumonia is what, and we've actually talked about this on the podcast, how important on revisions diagnosis is.
Correct.
When the diagnosis is further weight loss, they're like, sorry.
Right.
Correct.
But when the diagnosis is GERD and aspiration pneumonia, and they're like, oh, we just paid $40,000 for treating a pneumonia.
Yes.
For this hospital stay.
All of a sudden,
right.
all of a sudden, maybe we'll cover this.
Yes.
Yeah.
So you got aspiration pneumonia, and then that allowed you to leverage a different diagnosis.
With the insurance companies. And it still took a letter or two on my
Yeah.
behalf, writing the letters. I had esophagitis. I had the
Yeah.
GERD.
Yeah.
We had to send in the data, the EGD and the labs.
Yeah. So what was your weight before your band?
300.
So you got down to like 280, 275-ish, right? And then you ended up having a gastric bypass.
Correct.
And that was a while ago still, right?
Yes, more than 10 years ago.
More than 10 years ago.
Mm-hmm.
And so how was that experience?
Wonderful.
Yeah. And you had that here you had it in Phoenix.
I had it at a banner.
Had a banner.
Okay. Banner here in
Uh-huh,
Tucson? Oh,
Tucson.
okay.
Banner in Tucson.
Yeah.
Okay.
Tucson.
Oh, that's right. Galvini did it.
Yeah.
Yes.
Exactly.
Got it. Okay. So you have a gastric bypass and it goes very smoothly. It's a revision gastric bypass, right? It's band removal and conversion to gastric bypass. And so how much weight did you lose from that?
I lost another, I would say 70 pounds. I was about 190.
Well,
Okay.
that's good for a
Yeah.
revision. Yeah.
Because
That's
you're
a
also
substantial
you're
amount
quite
of loss.
tall.
Yes.
Yes.
Yeah.
Yeah.
So you get down to 190. That's you were probably loving that weight.
Yeah.
I
Not that
did.
far.
Is that
from
like
home
was
would be
that
mine.
your high school weight?
Actually, 170s with my high school.
So a little bit,
little farther.
a little bit over your high
Still
school
though,
weight,
for
but
a
not
revision,
much.
that's very impressive. Yeah.
And really you're 110 pounds down from your heaviest weight,
Yes.
Yeah.
right?
More so now. And then COVID hit.
Yep.
So,
So COVID hit, and that's when we started working together. It was
yes.
right at the
Mhm.
beginning of COVID. So we had a real kind of switcheroo at the hospital, and that's when I became the medical director of bariatric surgery, and we didn't have a coordinator. And I knew, especially because of some of the things that had happened there in the past, that we needed a quality person. We needed someone who was experienced. And we put out the
Mhm.
feelers, and Barb kind of limped in. She's like, I've heard some things about the hospital. I'm like, well, here's how things are going. We're going to do things a little differently. We're going to follow our outcomes every single month. We're going to talk about them. We're going to discuss them, and we're going to make sure that we have the lowest complication rate in the country. That is our goal. And we've gotten pretty close to that. I mean,
Yes.
we've
Yeah.
really moved in that direction very much.
I'm very impressed
Thank you.
with the
But a lot of that
program here.
was your leadership at the
combination,
hospital.
yeah.
Yeah,
Yeah.
setting up the program is so important.
Yeah.
Having the nurses know how to take care of our patients. Setting up our before and after surgery protocols. I mean, all of that plays into like what incredible
Yeah.
success rates we've had.
That's the
and
most
low
important.
complication
It's
rates.
such
Yeah.
a team effort.
It really is.
I mean, the nurses on the floor, our OR team. I mean, our OR team is so
Yep.
critical, and Barb
Yeah.
even gets to know them a little bit through this.
Yeah, really just care from beginning to end.
Yeah. And so talk to us about where you were in your bariatric journey at that point. You're about 7 or 8 years out.
And I started to regain a little bit.
Yeah. So about 7 or 8 years from surgery, COVID hits.
Right.
Anything else contribute to that weight regain? Or you think it was just COVID, the timing, or
Life.
life?
Yeah.
Life. Yeah.
And we
it keeps
it
rolling.
manifests itself in
Mhm.
poor behaviors on my
Right.
part.
Yeah.
So that's when I consulted with you.
Right.
And I do have some challenges, but we decided to do meds.
Yeah.
And
I
that's
think we
what we
originally
did.
didn't we talk a little bit about revision surgery?
We did.
And I said no.
Yes.
Yeah.
Yeah.
Truthfully, the success rate of the GLP-1 medications after bariatric surgery is even greater than before bariatric surgery. And you probably have lost more weight using the medication than you would have with a second revision.
You're
Oh,
right.
oh,
I'm
for
down
sure.
to
Definitely.
How much
175.
weight? So how much weight? So you're down to
75.
So you're 5 pounds over your high school graduation weight.
Correct.
Yeah, that's great.
That's awesome.
It's so awesome.
At retirement age.
At retirement
Yeah.
age, yes.
Yeah.
Barb is retiring, and she's kind of working part time
Yeah.
now. And so how much weight did you lose with the medications?
I think we started at 225 and I'm down to 175. So 50 pounds.
Yeah.
And you're 15 pounds lower than your lowest post bariatric surgery weight.
Easily.
Yeah.
That's
So this is also exactly where the combination therapy comes
Mhm.
in, right? And it is the surgery, it is the medications together, and it is also the nutrition and
Mhm.
exercise and lifestyle components as well. And so Barb's put every one of those pieces together. And she's had you kind of have like the quintessential lifetime experience of treatment,
Yeah.
right?
Going from band to bypass
Right?
and meds. I mean, that's Yep.
You're such a good coordinator because you've kind of experienced it all on the nursing side and also experienced it all on the
Mhm.
individual side.
yeah.
And I think that really that's what makes you so effective is that, when you're talking to our patients, you know exactly where they are. But it's been a journey.
Yes.
It's been a journey. And so what medication are you using now?
Well, because I'm on Medicare now, I'm not
Oh,
eligible for any
geez.
medication.
Oh,
So
no.
Okay.
that lends us that there's no coverage for
Yeah,
Medicare.
this year, as of January 1st, no Medicare Advantage plans.
So are you off the
No
meds?
I stopped them
coverage.
probably 7 months ago.
And you've been able to maintain your weight?
I gained 10 back, but I've lost 5.
Oh,
Okay.
great. Okay.
So I'm trying to use my behaviors,
Yeah.
modifications,
Yeah.
and working towards that.
I think that's something we're also seeing, is that a history of bariatric surgery makes you a little more flexible when we stop the meds. You know, when I'm thinking about a lot of the patients who we have, and I think we've had people on the podcast in the past where they're on monthly dosing as opposed to weekly dosing. A lot of them are post-bariatric surgery patients. And we're looking at this in our own database, that there's definitely some synergism between these medications and the surgery. And we're seeing better responses. We're seeing a little bit more durability of the medication-induced weight loss. And I think for you, what you may find is that you may once a year have to take a couple of doses of the med just to kind of reel
Pull
yourself
it back a little bit.
down,
Yep.
right? And that might be your journey in terms of weight maintenance. But it sounds like you've been able to tolerate stopping the medications quite well. Yeah.
Yeah. We do see like a rebound weight gain of about 5 to 10 pounds just because of the withdrawal of the hormone. That's pretty standard, but with nutrition and, maintaining good dietary behaviors, you were able to lose that weight you gained and then maintain it. So yeah, that's great.
Yeah. So is there anything else that you want to share? I think we've talked a lot offline about healthcare affordability.
The affordability for individuals, the marketplace is not a good option for people. They need to understand that when they're searching.
Right.
They need to use liaisons with their employers, that if their employer doesn't carry bariatric benefits, they need to rally together.
Right.
Advocate for those.
Advocate for
I have seen
those.
some success stories with that, believe it or
Yes.
not. So
Yeah. That's really when you have a bariatric exclusion, and for you, it kind of got pushed through as a revision. But if it's a first-time surgery, if you have an exclusion, I've never seen an exclusion overturned. Have you seen that? Where my employer doesn't cover it and the insurance company overturns it. You can get the employer to overturn it, but never the insurance company, where United says, oh, you have an exclusion.
Yeah, I have not seen that
And,
either.
but we're going to approve it anyway. I've never seen that. It's the employers.
Right.
Correct.
They
That's
wait
where
till
the decision is
turn
made.
year and they speak to their
Yes.
HR department and work that way.
They'll do a one-off,
Yeah.
an individual case.
Yeah. And when we look at healthcare affordability, in every other space, as technology ages, we tend to see it come down in cost. And as competition enters the market, we see reductions in costs. And that's generally how a market works. And we all kind of at some point have learned about supply and demand, right? Supply goes down, price goes up, demand goes up, price goes up. These market forces that just kind of change the prices and affordability. And over time, if there's an option for profitability, people move into the space and it kind of all works out naturally. Healthcare doesn't allow for that process. Healthcare prices are set arbitrarily and randomly. And that results in bariatric surgery costing $38,000 when it's paid through your employer, through United Healthcare. And then a self-pay price somewhere is $15,000. And Mexico is $6,000 in ambulatory surgery. You get all these kind of crazy prices, and the health insurance payments don't line up with the rest of the market forces.
Right.
And that's really unfortunate, and that's a huge component of it. The underlying problem is that the bodies that are determining the prices, which is the insurance companies, right? United Healthcare is the 9th largest company on the planet. They set the prices. This is what they're going to pay, and they're kind of like like Walmart used to be.
Right.
Maybe still is. I don't know. But they set the prices. The higher the prices, the more money United Healthcare makes, and they get a portion of the healthcare expense. And so for a long time, we've just had very little incentive for the insurance companies to set the prices low. And so that's why we're seeing what we're seeing. So there's so much room for improvement in healthcare affordability. But Barb, I think your story, your journey, it really illustrates to me what it takes to successfully battle obesity. Yeah. And you're there. You've kind of accomplished it. And I think the other part of that is that you still have some obstacles ahead as you kind of wean off the medications and dealing with that affordability. And I think that's to some degree true for everybody who struggles with obesity, is that there is no moment where you get to say, I won, I'm done, I can relax.
Right.
I don't feel that way ever.
Yeah, your experience has allowed you to be your own advocate through this whole journey, and you're going to have to continue to be your own advocate now that you are not going to be able to get the medications through your insurance company anymore. And there's things that patients can do, but they have to have the initiative and the knowledge.
Yeah.
And somebody to help them along sometimes.
I mean, look at Barb, who's an insider in the whole situation, and she still struggled and ended up in Mexico, for crying out loud. And so if someone like you is having to go through that, what hope do the rest of us have,
Right.
So, well, thank you so much for sharing your story. I think so many important and interesting things.
No idea all of that. Amazing.
Yeah. Well, thank you, Barb. We really appreciate you being on. And honestly, it has been such a pleasure to work with you all these years.
It's such a huge difference.
I take a lot of pride in our bariatric program. I think Deidre does as well. And you have played such a huge role in making it,
what it is. Yep, as successful as it is.
So,
absolutely.
So we wish you so well in your retirement, and we know you've trained Amanda up very nicely, and that she's going to fill in and take over and do a great job. But we will miss you. We will really miss working with you.
Likewise.
And you have to make sure you always stop by and say hello.
We'll definitely hear from you.
Right.
Thank you.
Thanks, Barb.
Thanks, Barb. It was so great to hear from Barb. She has just had so much experience in this. All right, Deidre.
Yes.
It's your turn.
Nutrition segment.
Yes, you're replacing Zoe. You're going to do the nutrition segment. So what do you have for us today?
I found a great article and actually a dietitian. I read a lot of dietitian articles while I was preparing for this. So I found a great article about walking after eating. And this is really good for bariatric patients because something bariatric patients experience in the beginning, especially in the first few months after surgery, is a lot of bloating. They get full very fast. Sometimes there's, kind of a hard time digesting. It takes a long time to eat your meals, drink your protein shakes. And I found an article about all the benefits of walking for even 5 minutes after you eat.
Yeah.
Walking decreases your glucose levels. It makes your glucose rise more slowly and fall more slowly. So you kind of maintain a more even blood sugar, which especially after gastric bypass, your blood sugars can be a little bit labile. They can go up rapidly in response to some foods like carbohydrates and fall rapidly, which cannot make you feel very good, right? Yeah. Nauseous, dizzy. It can increase the motility for your intestines and stomach. So for when you have to eat very slowly and you get full very fast, it can be very uncomfortable. Also, you get a lot of gas from swallowing while you eat, and that can make you feel very bloated. So walking helps kind of push the gas through, push the food through your stomach and into your intestines and through your intestines so that you're more comfortable. It helps with blood pressure, which is another thing that can be a little erratic after surgery sometimes. So even or walking for 10 minutes a day or 10 minutes 3 times a day can decrease both your systolic and diastolic blood pressure, which is great. And the most important thing is that it helps with mood. And we see a lot of mood changes after surgery, which a lot of people don't expect. Just because of the hormonal change in your GI system, that's connected to your brain in this gut-brain axis, right? And so changes in your GI hormones can affect depression, anxiety, can make it difficult to sleep. And walking actually increases endorphins, increases oxytocin, which is just a hormone that makes you feel really good. Yeah. And so it can make you feel better. It elevates your mood. It helps you sleep more regularly, which a lot of gastric patients or a lot of bariatric patients after surgery can't stay asleep for very long. Yeah. So that's really helpful.
I mean, I think there's so many reasons to do that. And I think it's actually, isn't it like an Instagram or a TikTok thing?
I think it's a very popular trend right now. Yeah. But really, I mean, it's been around forever, right? Yeah. Your parents used to go for walks after they ate dinner, because it makes you feel better.
That's what I was going to say. Is it really I try to do that as often as I can. And I just feel so much better when I walk after eating.
Absolutely. I think we're just so tired, and then eating makes you tired that because of the spike in insulin, the drop of insulin, right? You get the reactive hypoglycemia that we don't want to do anything. So getting out for a walk kind of levels everything out.
Yeah. So if you if you're looking for some help in controlling your food cravings, controlling your blood sugar, your mood, go for a walk after every meal. All right. So let's move into our economics of obesity segment. And today we're going to talk about self-pay bariatric surgery. Now we heard from Barb, who had to go to Mexico to end up getting her lap band and almost found herself in a position where she was going to have to go to Mexico for a revision, which, I mean, if the primary surgery makes you nervous, I mean, revision surgeries, we've done, you know, probably 500, 600 of these complicated revisions together. They're hard.
They're hard. The tissue integrity is not as great. There's a lot of scar tissue. The complication rate's slightly higher. So
and also the long-term care is more important.
Absolutely.
Right? You know, when we do complicated revisions, we're seeing patients a little more frequently in the office afterward, and you know, more phone calls. It's just a more difficult surgery. So let's just talk a little bit about self-pay. So first of all, who is self-pay for? A lot of patients don't think that their insurance will cover bariatric surgery, but 95% of policies will cover bariatric surgery.
Right.
Whenever someone has coverage for insurance for bariatric surgery, that's what they should do. They should not self-pay. They should use their insurance. It's just saves them a lot more money, and it kind of takes up some of the financial stress out of this. Unless you're just fabulously wealthy, then you should just use your insurance policy. And what we find is actually, and again, this kind of gets back to what we were talking about with Barb, how there's really no market forces in terms of healthcare payments. But when we look at self-pay bariatric surgery, actually the market it makes some sense. So you can go to Mexico and for somewhere between $5 to $10,000 get a sleeve or a bypass, which that makes sense because I think we all understand that the safety standards in Mexico are not quite
less regulation, right?
Less regulation. So the safety standards aren't what they are here, and so you're basically saving some money but taking some additional risk.
Also, no post-op care, which is going to be less expensive.
Right. Exactly. And then there's a big move right now. To perform bariatric surgery in an ambulatory surgery center. And what that really requires is that you go home that day.
Right. Which again, no follow-up care. So you save money, but you don't get the benefit of, you know, IV nausea medication, making sure you're hydrated. And if you need to stay extra time, you know, you get less
Post-operative support.
Specific.
I think that first night after surgery can be rough for some patients.
It can. We were doing for self-pay patients in another
We were
practice.
doing it for insurance patients too.
Right, where we would send them home and they would be in the office for IV hydration.
Yeah. The next
9
day.
times out of 10 the next day.
Yeah.
So
I do think it is possible to do ambulatory surgery safely, but it is a little bit of a rougher experience. We see the price for surgery in an ambulatory surgery center somewhere around $10,000 to $15,000. The other thing about an ambulatory surgery center is they don't necessarily have blood on site. They don't have an ICU. And again, that's not, I mean, our patients don't get blood.
Those
and they
things
don't
are rare,
need,
but it's nice to be available.
Extremely
if
rare.
it's necessary, you want to have it there.
But when you need it, you need it.
Right.
And so when you do have surgery in an ambulatory surgery center, that tiny fraction of a percent chance that things go very, very quickly south, you don't have that backstop that you have in a hospital. And then, you know, our self-pay prices are somewhere, I think, around in the high 15,000s for a sleeve and mid 17,000s for a gastric bypass. And that's in an actual hospital. And that's what we're seeing is somewhere in the $15,000 to $20,000. There are a lot of hospitals that don't have a self-pay price, and then it becomes $35,000, $40,000, $50,000.
Right, the add-ons, the anesthesia, the facility cost, the billing by time.
And so I think if you go to a place that doesn't have a self-pay program, you're going to probably pay twice as much as one who's actually put something together. So when you're looking at self-pay, you got to ask yourself what's included, right? Is anesthesia included? Like you said, all of these add-on costs. Is there no overnight stay? What about post-op care? You know, in Mexico, no post-op care. Is there nutritional support? All of those things. Our program, we include all of those in our price. We have it set up so like it's just this is what you pay, and then that's all you pay. We're done.
Right.
A big question that a lot of people have is complications.
Mm-hmm.
And so what happens if there's a complication? Will your insurance pay for it? Because the price can go from $15,000 to $20,000 to $100,000 like that. Over the years, I've had a few patients have some relatively minor complications, and we've always been able to get insurance to pay for it.
Yeah.
Especially if you leave the hospital and then come
Many
back.
times it's seen as a separate event.
Right. It's seen as a separate event. So we usually complications work out. There are some insurance policies you can get that will pay up to $50,000 and you pay like $2,000 or $3,000 for those. And those are interesting. And I think the problem is if you have to pay, if you have a bad complication, it's going to be a lot more than $50,000 most likely. So you should have your eyes wide open with this, right? You know, Mexico is the cheapest. You get less of the safety standards. ASCs in the US are going to be a little safer, but you may have a rough night at home. And also you don't have that backstop in case of disaster. And then full hospital is the safest option, but also the most expensive.
Right. There is some risk involved. So you definitely want to, research all the options and kind of minimize, do what you can to minimize the risk prior to making a decision this big.
Yeah.
So,
all right. So let's move on to our questions from social media land. Oh, we have Howell here. Howell works in the office, and he handles a lot of our workups for our insurance patients. So if you're one of our surgical patients, you've probably talked to Howell in the past, and he's going to read the questions. He's helping Sierra out. Sierra's got some trips planned, and she won't be around to help us produce the podcast. So here we go. So, Howell, what do we got for our first question?
All right. So the first question is, could Ozempic stop working after taking for 2 years? I've suddenly started gaining weight and can't stop it.
So what we see with these medications is not that they stop working, but patients build tolerance to the dosage. And how much tolerance and how quickly a patient builds tolerance is based on their response, which to the medication, which is many times genetic, right? How good of a fit is the receptor with the protein, right? So that they, are they getting the maximum response to the medication? I have some patients that after 3 months, they are no longer losing weight on that dose and they have to move to the next dose. I have some patients that 2 years later, they're on a very low dose of Ozempic and are still at their high school weight. So it's very individual on how quickly you build that tolerance.
Yeah.
What people don't conceptualize as their weight loss plateaus is that they are still getting some benefit from the medication. They're still getting smaller portion sizes many times. They're still getting appetite suppression, and it helps with their cravings. And until they actually have to stop the medication, do they realize that it's still having a positive effect. The problem is that the medication itself is not affecting weight loss, it's not causing weight loss. And that's where nutrition really comes into play. Nutrition and exercise, if you are going back into those healthy habits as some of the effects which are present but kind of start to wane, they become less effective, but are still there, you start to slip back into some of those old habits and let the nutrition kind of slide. And that's, usually where weight gain starts to come back. And so you have to get back into kind of a set point lowering nutrition plan to help reverse the effects of that.
I think this is really a set point question.
Yeah,
and I think if you look at this from a set point perspective, it'll make a lot of sense. And so let's talk about bariatric surgery. We see sleeve gastrectomy, nice lowering of the set point from the beginning, but then we start to see the set point creep up and people regain weight 18 months, 2 years down the road. We see that quite frequently. And so we know that the sleeve as a medical treatment kind of causes the set point to shift down and then to slowly go back up. We know a gastric bypass causes an even greater set point shift, and it tends to be much more stable. But we still see, like Barb talked about, patients start to regain weight at year 8, 10, 15, 20, sometimes never.
Right.
But that durability of that set point lowering is much better. So the big question I have is, what's it going to be for Ozempic and Mounjaro?
Right.
We don't know. I don't know that this is a known answer. I was talking to a patient today who had been on Wegovy for 2 years, and so was still doing exceptionally well in maintaining her weight.
I think it's going to be very individual.
Yeah. I think we're going to see a lot of variation.
A lot of variation, yes.
But so the question is, could Ozempic stop working after 2 years? And the answer is it could be. My guess is it's going to take a little longer. I think we're going to see the meds somewhere between a gastric bypass and a sleeve where we start to see some of
Right.
the effects wear off. The advantage of a med is you can increase the dose, you can
Mm-hmm.
switch to a different drug. So there's,
There are options out there. You can use 2 medications together.
Yeah.
But the first step, because again, it's not that it's really stopped working. It's just that the effects have lessened to the point where it's not really giving you the response that you are looking for, is nutrition. That's the number one thing you can do to help yourself without having, even if you don't have coverage for other medications, even if you don't want to be on medications for the rest of your life, nutrition is where to start.
Yeah. And I think the final thing to talk about is whether or not there's some other set point raising event going on. Have you started a new medication
Absolutely.
that causes
Right.
weight gain? Did you have an injury and suffered some muscle loss?
Mm-hmm.
Is there processed food addictions and nutritional sliding
Yep.
like you just mentioned?
Absolutely.
What else could be driving that weight gain besides the Ozempic no longer working? And again, this points to the fact that nobody's going to get through this whole obesity thing without having to constantly monitor, adjust, and change what they're doing to find success.
Mm-hmm.
And so I think this is something that is just going to continue. We're going to be in business, whether we're in the GLP-1 business
Right.
or the surgery business. We're going to be in business for a while, helping patients with all of these tools. And I think the more tools we have, the more success we're going to see.
Yeah, absolutely.
All right. So what's our next question?
The next question is from Joan, and it says, I had surgery a few days ago and I'm really struggling with constipation. What is the best way to treat it?
Oh, this is my
Deidre.
favorite subject. This subject is near and dear to my heart. I love constipation. Okay, so it's very common to have constipation after surgery.
Yeah.
And there's 2 reasons why. In the immediate postoperative period in the first week, it's ileus. Your bowels go to sleep a little bit with anesthesia. Also, for bypass, we are rearranging your intestines. And so
Right.
that causes them to not function as well. And so many patients in the immediate postoperative period, the first week after surgery, won't even have a bowel movement until everything kind of starts to wake back up
Right.
and function properly. We do prescribe Miralax after surgery, which is fine to use until it's as needed though. So once you start having regular bowel movements, you can stop using it. However, a lot of patients will continue to experience constipation for 1 to 3 months following that. And that's more dietary. You're getting a lot of protein volume,
Right.
not very much fiber, right? And fiber is what is basically a bulk laxative. It forces the stool through your intestines so that you can have a bowel movement. Without that fiber, you just have a lot of hard stool that's not going anywhere. And so in that period, it's still okay to use stool softeners kind of as needed. There's a lot of research that says that stool softeners are self-limiting and you shouldn't really take them after 4 weeks. However, sometimes they may be more necessary than we realize.
Got to do what you got to do.
But still, we don't want it to be long-term, right? The more natural way and what we try to move towards over the first 1 to 3 months is using dietary changes, adding fiber to your diet to help with constipation. So the first thing you can do in the immediate postoperative period when you're in the liquid stage and the soft stage for that first month is adding fruits and vegetables through smoothies, making protein smoothies with Greek yogurt or Fairlife milk, which is a protein fortified milk, and adding fruits and vegetables to increase the amount of fiber in your diet. You can also do things like beans, which are full of fiber, and other legumes. As you're eating a more regular diet, a more varied diet with more whole food fruits and vegetables, you're going to see less constipation. Now, there's a small percentage of patients after bariatric surgery that continue to have constipation. And some of that has to do with your GI system prior to surgery. People have idiopathic constipation and people have IBS with constipation. And the GI system, is not just about the bariatric surgery. The GI system was there beforehand. And then we can look at prescription medications for constipation, like Amitiza and Linzess. People on GLP-1 medications, especially semaglutide, really struggle with chronic constipation, even with high fiber diets, because that's kind of where you want to go. Your cravings tend more towards fruits and vegetables when you're on GLP-1 medications. And many times we do have to look at the prescription medications so that you're not on laxatives, osmotic laxatives, especially long-term, because they're starting to show more and more long-term side effects.
Yeah.
Oh,
You know
one more
a lot
thing about
about
constipation.
constipation,
Hydration.
Hydration.
Super important. And that's another thing that is you're always, even if you're meeting your fluid goals after bariatric surgery, you're kind of relatively dehydrated because 64 ounces is kind of just what you need to survive. You really should be drinking like 96 ounces or more, especially in the desert. So everybody's kind of always dehydrated, and that makes you constipated. Fluid is what helps stool move through the GI system. So.
Yeah, I think Deidre.
And yes, I do know a lot about constipation.
Deidre pretty much covered everything that anyone would ever need to know about constipation.
Literally every single day.
If you're out there suffering from constipation after bariatric surgery, book a consultation with Deidre. All right, what's our last question here, Joel?
The final question is from Renee, and it says, I understand the risk of long-term use of PPIs. What other options are available to patients like me?
All right. Deidre, why don't you cover the medication side of this? Besides PPIs, what else works?
So there are other types of acid blockers. The most common one that you can get over the counter and prescription are the H2 receptor blockers. We like to use famotidine, which is Pepcid. You probably have heard that. Tagamet is another example of an H2 receptor blocker. They also block acid, but from a different pathway, from the histamine pathway versus the proton pump pathway. Proton pump inhibitors do have a lot of long-term side effects we're starting to find, decreased calcium or hypocalcemia, because of that bone fractures, some gastric cancers, and now possibly dementia, although that's a little controversial. Yeah. H2 receptor blockers tend to have less long-term side effects. And so they have more immediate side effects like bloating. They're also more immediate release. They take effect faster, but they don't last as long in terms of coverage as PPIs. But overall, probably a better choice for kind of acute reflux. Now, we do require PPI use for 6 months after gastric bypass for patients who cannot take them, patients who have renal problems, some patients actually have allergies to PPIs. We can use H2 receptor blockers as an adequate alternative.
Yeah. What about like Gaviscon, Tums, and some of the antacids,
definitely.
Carafate?
Yeah, definitely things like Tums work. Carafate I kind of think of Carafate like Pepto-Bismol in that it coats the lining of the stomach, so it makes you feel better because you get a lot of gastritis and inflammation when you have reflux. You get bloating, you get spasm, you don't feel good, and that helps kind of just make you feel better. I'm not sure it doesn't decrease the acid production, but it protects the lining of the stomach from the acid production. Gaviscon helps with bloating for sure. I love to use Tums. I eat them all the time when I have reflux. So they work really well and you get good calcium from them. So
I think, the other part of this question is what if this is a sleeve patient? What are the options there? And I think there's a lot of pieces to that puzzle. So for mild acid reflux, we certainly don't recommend revision to a gastric bypass. But if you're kind of contemplating long-term use or once a day PPI isn't working and you're up to twice a day, and we know the natural history of reflux after sleeve is it just keeps getting worse.
Right, 2 years plus it's the highest percentage.
Right, and especially if you're experiencing some weight regain, then we talk about how diagnosis matters for revision surgery, and so. I think we're starting to see more and more patients opt for revision from a sleeve to a gastric bypass with really less severe acid reflux.
Right.
We'll see if the insurance companies catch on to this and start getting picky.
There's a lot of long-term side effects to having suboptimal treatment of reflux.
Right.
Ulcers, you obviously don't feel good. Nausea.
Barrett's esophagus.
Reflux aspiration, which can cause respiratory problems like pneumonia and asthma,
Barb
like Barb was talking about. Yeah. And so I think it's totally reasonable to both avoid the long-term consequences of chronic PPI use and those more serious side effects to consider revision at an earlier stage.
I think especially if the course is worsening.
Right.
If your symptoms are getting worse, then do you want to wait until you're absolutely totally miserable?
Right.
Which
if you can't control your reflux with max dose of proton pump inhibitors, it's very likely it's going to get worse.
Yeah, I agree. Yeah. All right. Deidre, you did an awesome job.
Thanks.
I'm so proud of you.
Thanks.
All right. This podcast is produced by Sierra Miller and Rhiannon Griffin, and the editing is done by AutoGrow. And I want to make a special thanks to our guest, Barb, not just for being on the podcast, but for all
Helping
of the
us for
service,
so many
the
years.
service she's provided to all of our patients and to the two of us over the years. Please check us out on social media at our website and consider joining our online nutrition program or our Pound of Cure Platinum program. And if you like seeing Deidre or hearing from Deidre, drop us a comment, let us know, and maybe we'll get her to make some Instagram or TikTok videos. What do you say? You in, Deidre?
Sure.
Okay, we'll see you guys next time.